All right, we will go ahead and get started now. It's about 10:34 East Coast time. So thank you, everyone. Good morning, good afternoon, good evening, wherever you are in the world. I know we have a global audience, so we're glad that you're joining here today. So my name is Chelsea Ryan. I'm the Director of Commercialization for Osiris Medical. Like I mentioned, we have a global group and we have people from all backgrounds today, cardiac, vascular surgeons, nurses, other medical device industry leaders. So there's a lot, going on in the world today, but we're happy that we have a diverse group here together and all sharing in the mission to improve lives for patients and outcomes for patients. So thank you very much for being here. We've got two great speakers lined up. So Professor Michael Borger, the Director of Cardiac Surgery at Leipzig Heart Center in Germany. And then we also have Professor Jorg Kempfert, Senior Consultant, Department of Cardiothoracic and Vascular Surgery at the German Heart Center in Berlin. Both of these gentlemen have extremely, vast experience in treatment of dissections, and both also have early experience using the Osiris Medical dissection stent. So we're excited to have them both joining us here today. Let's see. So just a few brief housekeeping items. So we're going to have ample time for questions and answers at the end of the presentations today. And how we're going to do that is through the Q&A function in Zoom. So please type all questions that you have throughout the presentations into the field within the Zoom platform. And we will make sure they all get answered at the end. And then lastly, a recording of the webinar as well as the PDF of the slides will be made available after the event. So we'll make sure those get sent out to you after the fact. All right, and without further ado, I'm going to hand it over to Professor Borger to kick things off.
Okay, thanks very much, Chelsea. I'm just sharing my screen now, and now I'm going to switch to my presentation slides. Thanks very much to Osiris also for the invitation to speak today about this very important topic about a disease that we all know is very challenging to treat. Luckily not too common, but common enough that we're in need of some alternative solutions to a disease process that still has about a 20% mortality rate. So the title of my talk is Challenges and Knowledge Gaps in Treatment of Type A Aortic Dissection. In case you're wondering, it's not evening right now in Leipzig and during the day in Berlin, like you may think from the background. Those are background pictures that Jorg and I are both using. So I'd just like to start by showing some famous people who have unfortunately died.
Hey, Professor Borger, we're not seeing your slides yet. Can
not seeing my slides yet. Sorry about that.
That's okay. There we go. Now they're coming up.
Can you see them now then, Chelsea?
Yes.
Okay. So as you know, there have been some famous cases of aortic dissection. John Ritter, the well-known actor, Michael DeBakey himself suffered a type A aortic dissection, Princess Diana, a traumatic dissection. Just some of the people that have succumb to this tragic disease. And we know that type A dissection has a terrible natural history. Here showing that with conservative management, that the mortality rate is about 60% by 30 days after onset of symptoms. And that surgical management is the only known therapy for this disease process. However, is unfortunately associated with a not insignificant mortality rate. Type A aortic dissection occurs approximately 2,000 patients per year in USA, about 400 to 500 times per year in Germany. Mortality rate 1 to 2% per hour, as we all know, for the first 48 hours, and then it drops thereafter. And 15 to 25% of early mortality in surgical series. And we know that the mortality rate is also higher if organ malperfusion is present at the time of surgery. And despite advances in our treatment of this disease process, there will be patients that will even develop complications after successful surgical management. And that's about 15 to 30% of patients that will eventually develop aortic dilatation or rupture, which is the most common cause of death, progressive aortic valve regurgitation, or organ malperfusion that needs to be treated with some other type of intervention after the surgical repair of the type A dissection. The entry tear, as we all know, most frequently occurs in the ascending aorta on the convex portion just above the sinotubular junction. About 10% of patients have a tear in the aortic arch and 20% in the proximal descending aorta. And the distribution of tears is very important for use of the Osiris device, and this is something that Jorg will be talking about in detail. The goals of type A aortic dissection surgery are, number one, to get rid of the intimal tear, so the primary tear, which is not always possible in all patients, but if it's in the ascending aorta, this should certainly be done in 100% of patients. We want to decrease or obliterate blood flow into the false lumen of the dissected aorta. We want to always replace the ascending aorta in all patients in order to prevent future pericardial tamponade or coronary or aortic valve complications if the dissection spreads more proximally. And aortic arch surgery is done most of the time in most centers. In our center, our standard operation before using the Osiris device was at least a hemi-arch procedure. We want to make sure that the aortic valve is competent at the end of the operation using whatever method that may be necessary to achieve that. And we also want to try to correct malperfusion. And this is something that we sort of just kind of hope happens at the end of the operation. But with the Osiris device, we now have an active way of intervening in order to correct malperfusion. So from our center, combined with the experience from Nova Scotia, we published this paper in Annals of Thoracic Surgery in 2016, where we looked at 534 consecutive patients with acute type A dissection. We wanted to develop a risk score for mortality in these patients. And these were the different risk factors that we analyzed in univariate and multivariate analysis, all of the sort of standard type of risk factors that you would expect for a type A dissection population. And we see that hospital mortality was highly dependent upon malperfusion. Mortality was much lower if there was no malperfusion present, but particularly coronary or visceral malperfusion were deadly entities that had a significant effect on the patient's outcome. And when we did a risk-adjusted multivariable analysis for mortality in this large group of patients, we saw that malperfusion syndrome was a statistically significant predictor, in particular visceral malperfusion with the odds ratio of 3.0. The importance of malperfusion has been demonstrated in many different publications, that it leads to increased mortality, it leads to increased reinterventions after the procedure, it leads to increased malperfusion syndrome after the, is associated with new post-op malperfusion after the operation, as well as a very high rate of stroke. In addition, those rare patients that present with paralysis pre-surgery almost never have resolution of their paralysis after a conventional type A dissection operation. So the Osiris device enables us to approach this malperfusion syndrome in a very active form. It's not the only way of approaching malperfusion. There's also, as we know, the frozen elephant trunk operation using a hybrid stent prosthesis in order to expand blood flow into the true lumen and decrease blood flow into the false lumen. Having said that, for those of you who have done frozen elephant trunk operations, you know that this is a challenging operation to do because you're performing an anastomosis very deep in the chest under elective circumstances. Under emergency circumstances at nighttime with a dissected aorta, it's a particularly difficult operation. This is not something that every cardiac surgeon can competently perform for every type A dissection patient. And that's why we think the Osiris medical dissection stent is such a advance because it's something, it achieves basically the same sort of outcome as you do with a frozen elephant trunk operation or a similar sort of outcome, but is much more easy to perform and is something that can be performed by a larger number of surgeons. Jorg Kempfert will describe it in detail and show a case video, and therefore I will not show it too much here, but just to explain again that the goal is to increase flow into the true lumen and collapse the false lumen in the aortic arch and proximal descending aorta while getting a good seal at the proximal suture line, just proximal to the brachiocephalic trunk. Why is that good seal there so important? Because we know from previous studies that a new distal anastomotic new entry, a DANE, is present in 50 to 70% of patients after a conventional type A aortic dissection operation. And these DANEs are a malignant entity in that they lead to pressurization of the false lumen at the very most proximal portion of the dissected aorta, leading to true lumen collapse and possibly malperfusion and definitely to rapid aortic growth. As you can see in this example here, after a previous open hemi-arch anastomosis, you see this large DANE right at the anastomotic suture line, denoted by the black arrow, followed by dilatation of the aortic arch and proximal descending aorta. Bartosz Rilski and his group in Freiburg looked at this carefully and found that the location of the luminal communication at discharge plays a large role on the future dilatation of the aorta. So if the communication, the more proximal it is, the more the aorta tends to dilate with time. And they found that this DANE, which they had a different name for, but DANE seems to be the most common sort of name we have now in the literature, was highly associated with accelerated aortic growth after the surgical repair. And we also know that DANE, which can also be demonstrated using TEE alone, as it was in the IRAD registry, that it can be shown in about 45% of type A dissection patients post-repair, and that these proximal entries are associated with worse long-term survival and more rapid aortic growth and negative remodeling of the aorta during follow-up. This is another study from Japan that was published in EJCTS in 2017, showing that if you have a patent false lumen without a DANE, that is the best prognosis as compared to a patent false lumen with a DANE with regards to long-term survival rate and aortic growth. So this proximal suture line opening into the false lumen is a not clearly identified entity from the past, which we now know has a very adverse effect on long-term survival and long-term aortic remodeling rates after a type A dissection. And we now have an active treatment therapy against this entity. So in conclusion, type A aortic dissection is a highly lethal disease requiring emergency surgical intervention. Mortality rates remain high after successful surgery, technically successful surgery, with malperfusion being a significant contributor to these mortality rates. And even in a patient that has a successful surgical repair and is discharged home from the hospital in a clinically good condition, we know that the DANE is associated with a significant proportion of future aortic reinterventions secondary to dilatation or rupture. With that, I'm going to stop sharing my screen and I'm going to move over and hand the host capabilities to Jorg Kempfert in Berlin. Jorg?
Yes, thank you, Michael. Welcome also from my side. Let's see how I can share the screen. Now you should be able to see my screen. Let me bring up the slides. Here we are. Okay, so hopefully you're all seeing my screen now. Chelsea, good? Are we good? Michael?
Yes, all good.
Yes, perfect. Okay, so Michael has nicely pointed out the goals of the primary type A procedure we're all familiar with. We all know that it's not an easy task in the middle of the night typically. God knows why they're always in the middle of the night. And he has also nicely pointed out the two major goals we want to achieve. So number one is we want to definitely treat or get rid of malperfusion. And secondly, we want to get rid of these thing that is called DANE. And honestly, I wasn't aware of that fact until a couple of months ago. I think these papers were there in the literature since ever, but somehow we're a little bit overlooked, I guess. So now we're coming to the second part of the presentation, which is where I would like to show you the concept behind the AMDS device and how it should be used or can be used. And I'm going to show you a video later on. So the indication clearly is type A dissection, not the chronic versions, because that the membrane is too stiff to widen the true lumen, but the acute onset is, these are the patients where it can be used. And the idea is to firstly seal the so-called DANE, so the tears that are induced by conventional suture lines, and secondly by widening the true lumen to get rid of static or dynamic malperfusion. On the upper image, you can see the helical non-covered self-expandable stent, which has quite large cell cells, so it can be sitting in front of the supraaortic vessels without any impairment of the flow. Also, you could do a secondary intervention through these meshes if required later on. And then you can, the downside, on the lower picture, you can see the delivery system. It's basically relatively simple. It can be used over a wire, but it's not mandatory because it has a pigtail shaped tip. So let's come to the mode of action. So number one is we want to get rid of these so-called DANEs, so these proximal new entry sites that you induce when doing a conventional open anastomosis or hemiarch. And we all think that it does not happen if we do it because we have a meticulous technique, but if you believe the literature, and this is not true, and it's going to happen to all of us in roughly 50 to 70%, and it has been shown that this is clearly associated for so-called negative remodeling in midterm or long-term follow-up. So how should this device help you in getting rid of this stain? So number one, it has an integrated felt that is going to be inside of the aorta, and then the self-expandable stent is going to compress the layers, and this seems to be the mechanism behind the concept, and it seems to work pretty well. I'm going to show you some data in a minute. And the second task is definitely to open up the true lumen to restore blood flow and hopefully to get rid of all downstream malperfusion issues. So coming back again to the DANE issue. So on the left side, you can see the standard kind of sandwich anastomosis. And typically you do have a felt on the outside. Some of us also like to use the felt on the inside or pericardial strip or whatever to kind of buttress the stitches, but still you will never be able to avoid these micro tears that then can pressurize the false lumen, which is the beginning of the so-called negative remodeling over time. So how can the device help you to seal this area? So number one, it of course also has a felt, but most importantly, just distal to your classic anastomosis, you will have the compression induced by the self-expandable stent, which will compress the layers. And this seems to be quite effective in sealing this particular area. And number one, this is obvious. You want to widen and open up the true lumen. This can happen in a more gradual fashion. So it could be that immediately after implant you have something like seen in the middle, and then over time you hopefully will see a nicely completely healed arch and ideally obliterated false lumen in the descending. So this is one of these ideal CT scans. This is what you should expect from using an AMDS device in an acute type A setting. I'm not sure if you can see my mouse pointing. Can you see that? Yes, okay. So this is the proximal sandwich anastomosis. This is free of any of those entries, so no Dane. And then you can see a nicely healed arch. The membranes came together very nicely. And only in the most distal part of the stent, you see some residual false lumen. And obviously, distal to the stent end, you'll see the typical residual dissection, but without hopefully any further downstream malperfusion issues. So how do we know that this device is actually effective? So the most robust data that has been collected as of today is based on the multi-center international DARTS-1 trial. This trial was designed to get CE mark approval for the device, and it was performed in some Canadian and some German centers. So in total, 47 patients were included, always type A, mean age at 63. 55% of those patients presented with some sort of malperfusion. The implant time was recorded with less than 5 minutes. 30-day mortality was quite, I would say, comparable to most high volume center results, 13%, slightly on the lower side than what you will see in the literature. Sealing of the Dane, this is important, was achieved in 90%. So it did a tremendous job in sealing these new entry sites at the distal anastomosis. New postoperative stroke, quite favorable, 6.5%, quite good. 0% of spinal cord injury, so this is obvious. This is a non-covered stent, so it's different to a frozen elephant. It simply cannot happen. The device seemed to be able to relieve the malperfusion, either dynamic or static ones, in 95% of patients. Arch showed positive remodeling in all patients, and a complete arch false lumen obliteration or thrombosis was seen in roughly 75%, and the descending aorta showed positive remodeling in 80%, and there was none device-related event reported, so no descending rupture, any of the nasty stuff. So quite promising data, but clearly a small group of patients. However, if we have a look now in the CT follow-up, and this extends up to 2 years now, you will see on the right side, each column is representing a different aortic zone. So the column named A is for the arch, and then B1 is proximal descending, and so on. And if you just focus on A, which is the arch, this is the one you want to kind of treat when entering through a stenotomy, then you can see that in regard to total arch diameter, there was no growth at all. False lumen also was decreasing, and true lumen was not increasing. So you could draw the conclusion from this CT follow-up data that it was super effective in healing the arch. In B1, which is the proximal descending, there was some yellow patient, meaning that there was no decrease, and there was only one patient which is here representing with that red one, which showed total diameter growth, and this was due to a pressurized false lumen flow through a dissected left subclavian, and this patient was treated by interventional methods, so they recoiled the subclavian, the carotid subclavian bypass, and therefore minimized the true flow, the flow into the true lumen, the false lumen, sorry, and this patient did not show any signs of deterioration during follow-up CT scan. And if we have a quick look on the overall survival curve, you can see the blue curve. This is the overall survival. It's the usual pattern. Of course, there is some perioperative mortality, but then it flattens out, so no further events after the procedure. And the red one is freedom from aortic related mortality, which was none so far, fortunately. So let's have a look on how you actually deploy or use the device in a real world scenario. And this was a case that we filmed in the middle of the night. This is why it's not a super professional quality, but it's hopefully good enough to show you the technical details. So let's have a look on the patient. So it was a 65-year-old male that presented with acute syncope, was disorientated and showed an acute onset left hemiparesis. And if you have a look on the CT scan, it's obvious there was a complete occlusion of the common right carotid artery. the left one was perfused. And other than that, it showed a typical picture of an acute type A dissection with an anterior in the ascending, some true lumen collapse in the arch, and then the usual dissection extending just above the abdominal bifurcation. So in regard to the sizing, and this is always, of course, one of the questions you might have, how do you size the devices to the given anatomy? And what you should do is you should do a multiplanar reconstruction. We like to use Terrarecon for that, but you also could use Strumengio or the Singovia CT workstation or any other program that allows you to show the anatomy in two different planes. So you need to have a look at two distinct landmarks. So zone 1 is between the innominate artery and the left coronary carotid. This is depicted in this picture here. And in our case, this was 37.5 millimeter. And the second one, so the distal reference marker, so to say, is at the level of the pulmonary artery bifurcation in the descending. And this was measured with 29.5 in our case. And the next step, you need to grab the sizing chart that comes with the packages. And what you can see here in our case, we are suggested to use this configuration of the hybrid device, which is basically, it comes in 4 different configurations, tapered and non-tapered. And in our case, we are suggested to use the larger one in the arch and the smaller one version in the descending. And this is also what we have decided to do. Now, in regard to cannulation techniques and perfusion strategies and stuff like that, I think we could host a separate webinar just addressing this discussion and kind of different opinions. But just, I want to talk you through our decision making. Obviously, we are kind of worried about the right brain perfusion because of the occluded right carotid and the neurological symptoms which corresponded to that, left-sided acute onset hemiparesis. So of course, one option would have been to directly cannulate the right carotid with a side graft in addition to another arterial cannulation site. This is definitely one strategy that could be utilized. In this case, I decided to use right axillary artery cannulation and direct Sellinger technique using 18 French cannula as a single artery cannulation site. And the percutaneous right femoral vein. I like to do that in all type A patients because it allows you to start CPB and start cooling before opening the pericardium. And just in case you are kind of confronted with a contained rupture, then we all know how this can end up. If you're not on pump and if you're still warm, then you can create a real mess. But if you're already at 30 degrees, then you can directly initiate distal arrest and just continue with unilateral or bilateral brain perfusion. So the strategy for this case was single right axillary artery cannulation using direct Sellinger technique, percutaneous right femoral vein, start the CPB, cool to 28 core temperature. Of course, we need to carefully monitor the CPB pressures and most importantly, the nerves as well as the carotid flow because we are worried that there's not enough flow to the right-sided brain. So the nerves seem to be pretty stable after CPB initiation. And most importantly, we monitored the flow in the right carotid. This is standard approach in our center with a standard echo Doppler. This is done by the anesthetist. And we can see that after true lumen perfusion, the right carotid opened up. Clearly there's some dissection, but we decided this is enough flow to get us cool enough to actually do the arch. And then the other planned procedure obvious involves the replacement of the ascending, root reinforcement or replacement, and the usage of the hybrid arch device with an AMDS 55, so larger version, and smaller version 40 in the descending. So this is the actual case. So we are already unpumped through the axillary artery and the femoral vein. We are cooling. Now this is the dissection of the supraaortic vessels, opening the pericardium at 30-degree core temperature. I like to use a retrograde initial shot of cardiplegia and then add another antegrade shot once the situation has been stabilized a little bit and things are a little bit clearer. I've snared the left carotid and in a minute I'm also going to clamp the left subclavian to avoid any steal. So it's a unilateral antegrade perfusion strategy with 28 degrees Celsius core temperature in this case. This is the clamping of the left subclavian. Now this is the addition of the antegrade quadriplegia. And now most importantly, and this is something that is different to your standard hemiarch procedure, you want to leave some tissue remnant at the inner curvature. This is something that you should not do if you do a classic hemiarch, but for using this device, this is extremely important. So you have seen preparation of the device takes only a couple of seconds, just rinse it and then insert into the true lumen. I've not used the guide wire yet. It could be used, but I don't see the point. The tip is very atraumatic and I don't see any reason to actually further complicate things. And then you would just push the device in until the felt is at the level of your proximal arch. And then you remove the plastic covering. This is giving you access to the felt. And now in the first step, you should take 4 interrupted sutures over an external felt strip and then tie them down. And the purpose of these sutures is to, first of all, to kind of to have equal distribution of the felt from the inside, and most importantly, to secure the proximal part of the device to the exact level of your proximal part of the arch anastomosis. And only then, once the device is fully fixated, then you're going to open up the stent. And this is done by unscrewing the green cap. The red is to be ignored. It is of no purpose actually. And then you pull that suture, and this is going to release the stent in a self-expandable fashion. And then you obviously retrieve the delivery and you are done with the implant. Now in the next step, this is an important step, you should continue with a running suture to create a classic sandwich, but it's not a classic, it's also supported from the inside by expansion of the stent itself. And this step is the critical one to get rid of any potential dane. And now once this is finished, you should have a rock solid proximal arch sandwich that will allow you in the second step to use whatever graft you want to suture onto. And we're going to have a look into the arch in a minute. It could be that the stent is not fully expanded yet because you're still not warm and it's nitinol, but you can see the concept. So it will definitely help you to stabilize the membranes or the layers just distal to your anastomotic sandwich. So now the next step is to suture a standard graft onto that. You could use one with a side branch for perfusion if you want to change your perfusion site, but in this case, I decided to use a standard 28 straight graft. Just before completion, obviously, you need to de-air, and then you are done with your proximal anastomosis. And I always do the arch first, so no cross-clamping of the dissected ascending. I like to use the cross-growth clamp, which is very kind of nice clamp to get to stay out of your way. And now, of course, you can start full rewarming. You need to deal with the root. Of course, there are many ways to deal the root. You could do a David procedure, which I would consider only an option in a very young patient because it substantially prolongs cross-clamping time. Typically, biological full root would be a nice option, but in this case, because the dissection did not involve the coronaries and the leaflets look quite good to me, I decided to do the quick and dirty proximal sandwich with some French glue. And the reason for that is I was still worried about the fate of the right-sided brain perfusion. I want to get patient off bypass with pulsatile antegrade flow as soon as possible. And if you do a sandwich, I mean, of course, there are many ways to do it. I like to do 3 felt stitches above the commissures, an external felt strip, and then a mattress and an additional running layer of sutures. And then, of course, you need to complete the procedure by a simple proximal anastomosis. Usually, you will be releasing cross-clamp when already fully rewarmed. So this is actually a quite relatively quick procedure. Typical distal arrest times are 35, something like that. And with that, you are done with that procedure. But still, we were not sure about the right-sided brain perfusion, obviously. So this is the intraoperative TEE showing no aortic regurgitation, also widely open true lumen in the descending, but most importantly, of course, was the perfusion of the right-sided brain. This is why we decided in this case to immediately do a supraortic angiography, and you can see a nicely patent right carotid. So it seems to actually work, and we were quite relieved to see this angio here. This is the post-op CT scan. I would like to draw your attention to the root. You see absent of any residual dissection. This is the distal descending, which nicely kind of open up true lumen, only minimal residual false lumen visible. Of course, more proximal, there's more residual false lumen still present. And if we look on the clinical course, fortunately, this patient could be extubated on day 2, on regular ward day 3, and then was discharged without neurological impairment. And with that, I would like to thank for your attention, and I would like to hand over again to Michael to sum up and also to introduce us to the Q&A and the discussion part of this webinar. So let me see how I can make you the host again, Michael. 1 minute.
Thanks very much, Jorg. That was a fantastic presentation, as always, from you. Great video. Chelsea, I do believe that you are going to introduce the questions, or should I be reading the questions?
I think you are the host now, Michael.
Yeah,
Okay.
I will do the questions, but I think there's the couple summary slides if you want to go ahead and go through those, and then we can get to some of the discussion.
The summary slides, okay. Let me get to those quickly. Can you see my screen?
We can. If you stop
okay,
the presentation mode, I think then they're just
can you advance
my slides.
Can you advance the slides then, Jorg? We're still.
Do you not have? You should have control over your computer now.
Yeah, but for some reason, there we go. Okay.
There you go.
Thank you.
Yes. So summary and conclusion. There we go.
There
okay.
we are.
Okay. So these are the benefits from the Osiris AMDS device, and I think these points have all been covered, but I really just want to re-stress the point that it is basically performing roughly the equivalent of a frozen elephant trunk procedure in some ways, in that you're improving malperfusion and hopefully decreasing negative remodeling of the aorta, but making it a much more simple, reproducible procedure that most every cardiac surgeon can do even in the middle of the night. Very important is to stress that a tear in the aortic arch is, from the industry, from the company, not recommended that these patients are treated with an AMDS device. There has been a couple of patients that have been treated that way off-label. I don't think that it's a good idea. If I see a tear in the aortic arch, then I do a full arch replacement, which you see on the right side of this diagram. But then for the other 90% of patients that do not have a tear in the arch, we think that the AMDS device is a very nice solution, even for patients without malperfusion. So we'll get to our Q&A session. Sorry, I jumped ahead of myself here to the thank you slide. So we do have some questions already sent in.
Yes.
And Chelsea, maybe I'll get you to go ahead and start with them.
Sure.
You need to make her the host again.
Oh, yes. Yeah. Can you hand the hosting back?
I gotta get the, oh, sorry.
That's all right. We're all learning as we go with Zoom, huh?
Yeah, you know what, let me just stick with this slide, but Chelsea, you can read the questions, right?
Sure, yeah. So first question we have here, is this device amenable to completion TVAR post-acute repair? So
maybe I'll go with that one then, Jorg. To the best of my knowledge, there's not been a TVAR done. There's only been about 140 of these devices implanted worldwide. And in our center, we certainly have not done a TVAR after one of these procedures. Having said that, theoretically, there's no reason why you wouldn't be able to do it. as long as the re-entry tear that you're going after is in an appropriate location. So in the proximal to mid descending aorta, with enough of a proximal landing zone without obstructing one of the supraaortic vessels, then there's no reason why you couldn't perform a TVAR in order to seal that re-entry site. Jorg, do you have a comment to that?
So the question is, why would you do a TVAR post type A repair? And I think that is due to the thing that is called negative remodeling, right? I think this is a term that we should a little bit explain, Michael, right? Because most of the data of the AMDS is in regard to positive, negative remodeling. So
right. So sorry for jumping in. So there's two indications. One is either an absolute diameter indication once you exceed 5.5 or 6.0 centimeters for the arch or descending aorta. Having said that, if you've reached an absolute diameter criteria, you probably should have done a more extensive operation at the beginning of the procedure or at the time of the type A dissection. Or the other one is of course, rapid aortic growth, which is defined as more than 3 in some statements and more than 5 in other statements, millimeters per year. And as you are alluding to there, Jorg, with this device, we have not seen that rapid growth thus far. It is still an early experience. We only have a couple of years experience with it worldwide, mostly in the Canadian centers for the early experience. But the data just shows that there has not been that rapid growth, and I think that's why we haven't seen any endovascular procedures being done thus far.
Maybe we continue with more questions, and then at the end, maybe we can show one case, that's actually a Berlin case, that required a re-intervention. It's the only case so far that showed so-called negative remodeling in the proximal descending, and we can show how this was solved interventionally.
Great.
Yep. So next question is similar with regards to kind of following up re-intervention. So question, often after a classic open hemiarch repair for an acute type A dissection, patients come back for a redo total arch secondary to arch descending aorta progressive degenerative expansion. In those cases where the AMDS device has been used, and if unfortunately did not succeed, does anyone have experience with performing a redo total arch once this device is in place?
This has definitely not been done. And I expect, we're going to have to wait a long time before one of these operations will need to be performed. There is going to be some patient in the future that will require it in any case because of a large re-entry in one of the supraaortic vessels, for example, that leads to expansion of the arch. But I don't think we'll see the first patient for another 5 to 10 years. Redo surgery or arch surgery or a descending aorta surgery with a pre-existing stent in place is never a fun operation. I don't know how many stents I've pulled on a patient's aortas. And we have to just see what happens under those circumstances. But just 2 points I would like to say is if you want to try to get the stent out, this is a nitinol stent, so you could put ice on it, analogous to a core valve. You could just put ice on it, and then that will make it much more flexible, and it'll help you a lot to bend it together and try to pull it out. Or the other option is what we do for most TVARs is just simply to cut across the wires individually with heavy scissors, and then just sew around those wires. I've done that many, many times, and it works. It's not fun. It's not an operation you wish on most people, but it can be done, and certainly in centers with a lot of experience, it can be done.
Great. A question on the sizing. Can you please go over the sizing again? How much do you oversize? Another question on what is the max arch diameter? So if we could maybe, you can either hand the host capability back to me, or you can go back to that slide and show that. We have it in the backup slides, the configurations.
Let me see if I can get back. I'm having a hard time finding my darn Zoom. It just...
Can you hand it back to me, maybe? Maybe that would be easier.
The problem is when I click on the Zoom down here, nothing happens now.
Do you see my picture?
No, I don't.
Oh.
I don't. That's my problem. Everything seems to have been collapsed here. I guess you guys can all see my laptop now, right? And I'm flipping around like crazy. But when I go down here on Zoom, I don't know how many times I've clicked it, and I cannot.
That's okay. If you open the slides again,
so which slide do you want me to go to then?
Go down
Chelsea?
to the bottom, the backup slides. We have the configurations, and we can talk. You guys can talk through the sizing. Slide 51.
Yeah. So maybe while Michael is looking for that sizing chart, there it is. So I mean, the only thing you need to do in an ideal scenario, what you should be capable of doing in the middle of the night, you should be able to either have a radiology and wake the radiologist up, or this is what we do, you learn how to use a kind of a dedicated CT software. It could be any, there are many companies, and the only thing that you need to do is you need to measure the cross-sectional diameter between the innominate and the left carotid. And clearly this cannot be done by standard kind of by standard CT images. You need to reconstruct the arch a little bit. In a descending, and this is the distal kind of landmark, it's very easy. Just scroll down to your pulmonary artery bifurcation and then measure the diameter of the descending there. So in case you are desperate and you do not have the adequate software, or you still lack the skills to use it, it's not a shame. Then one very kind of dirty workaround is you can use this sizer of a mitral valve prosthesis. And then whenever the sizer is above 33 in the arch, then you should go for the larger configuration. And if it's below 33, then you should stick to the smaller one. And I think if you approach the company, they can provide you with some slides showing the kind of quick and dirty workaround for dedicated CT softwares in the middle of the night. But ideally, you should do CT-based sizing. And then you have the sizing chart, which is relatively easy. Just I think, Michael, it's not a sizing chart, but the configuration of the, do we have the sizing chart?
Might have to go back to Jorg's slides where he had it.
I think I had it in my slides. So there are 4 configurations.
35.
2 straight versions and then 2 tapered versions. And basically, to kind of, don't make it too complicated, think of small and large versions, and then they can come as straight versions and tapered versions. So you should measure, it says here, diameter proximal aorta, and which is between the innominate and the carotid. And then you have a look. If it's above 35, use the larger one. It's below, use smaller. And then you scroll down to your pulmonary artery bifurcation, measure the diameter in the distal aorta there, so the descending. And then it's the cut up there is 36, I guess. So it's relatively straightforward, except the CT reconstruction. Michael, how do you do it?
Well, I don't, the CT reconstruction in New York, I'm to be honest, I haven't had to do that, but mind you, I play around with a lot of aortic CTs, and I can get a good estimate of the size of the diameter of the aorta in the mid-arch using the most standard pictures that are supplied for the CT. But I understand what you're saying, and I think that would definitely be the best way to do it if you have that capability in the middle of the night.
Mm-hmm. All right.
Sorry, everywhere I click on here, Chelsea, I cannot see your picture anymore. It's just completely gone. Anyways, let's go to the next question.
That's okay. Yeah, so maybe for both of you, is everyone on your team capable of using the AMDS?
So in Leipzig, we've got 16 surgeons, and we have 4 backup surgeons for very difficult cases and 12 primary surgeons. And we are in the process of getting everybody trained on the procedure. Right now, we got about 2/3 of the people trained on the procedure, but everybody that's done it has found it not very challenging. Jorg?
Yeah, it's the same in Berlin. So initially, of course, it started in a smaller team, and now whenever there's a dissection and anybody has not used it, they call one of those guys who have done a case, and after one single case, they feel comfortable to do the following one alone, because it's actually very simple, but it is as usual. You need to do one to feel really comfortable.
Sure. So a question around, can this be used if the primary entry tear is in the arch?
Jorg, go ahead.
I would say I would not use it if the patient is fit enough to undergo a classic, I would use a classic frozen elephant in those cases. If the patient is really old, kind of came into severe malperfusion, this kind of stuff, if you're kind of desperate, you can give it a try, but it is officially not recommended. We had one case where we used this. This worked okay, I would say. The result was enough to get him out of shock and malperfusion, but the arch didn't look super pretty on a CT scan. This is why my take on it would be, whenever you think the patient is fit enough to survive a classic frozen elephant or a standard arch, go for the arch, get rid of the tear. If you feel desperate, it's off-label, yeah, you're allowed to do anything that you think is good for the patient. But there's, I think, another case from another German center. And Michael, have you had any experience?
I wouldn't do it if there's a tear in the arch, but there was that one case that has been shown from Dusseldorf where they had a complete healing of the arch, even though the whole arch was torn. But they said it was a very high-risk patient, and it was sort of a Hail Mary. It was a Hail Mary that worked, but I know I would be not sleeping very well that night, worried that maybe you're going to have life-threatening bleeding later, but it worked well.
Mm-hmm. We've got some questions regarding malperfusion and supraortic vessels. So how does this device manage the reentrance and tears at the level of the takeoff of the supraortic branches? How is this technique superior to a full debranching and TEVAR?
So I would say, the reentries that are in the supraortic vessels, we don't treat anyways. And the primary management of those tears is increasing flow into the false lumen in the proximal aorta. And in that regard, this is a perfect device for it. Mm-hmm. The situation like Jorg had with his case, where you have an occluded coronary artery, we have to always make sure that you differentiate. When I talk to my residents, I always say, look, just because a vessel or an aorta is dissected doesn't mean we resect it all. There's limits to how far we can resect. But occasionally you see ones where there's thrombosis in the false lumen, and that leads to either a stenosis of the vessel or a complete occlusion, like in Jorg's case. And to be honest, in that case, I would have been a little bit hesitant about just going with the axillary perfusion during the circulatory arrest time. I probably would have stuck a perfusion catheter between the cells into the left carotid artery as well. But as he demonstrated there, the carotid artery right carotid artery was open at the end of the procedure, which is really astounding.
Mm-hmm. Yeah, maybe from my side, first of all, to the topic of antegrade bilateral versus unilateral perfusion. I mean, this is a hot topic. Evidence is kind of contradictory to that. Some data shows that bilateral is worse than unilateral. Some data show the opposite. So my take on it is it is extremely important to occlude the left subclavian to get rid of any steel if you use unilateral brain perfusion only. And with that technique, I think it works well. I have to admit, in case of a full arch, so a frozen elephant, I also would use a perfusion catheter in the left carotid, because obviously the distal arrest times are longer. In regard to the arch tear, I mean, if you have a distal arch tear, then I think the only option is to take the arch. If you have a typical entry tear in the area of the innominate artery, then of course one option is that you can also transect the arch in between zone 2 or zone 1, and then suture a branch prosthesis to the AMDS, and then kind of rebranch the innominate or even two vessels like the innominate and the carotid. You're still a little bit kind of faster than doing a full arch with all the three vessels.
So to get it straight then, so you are not using left carotid perfusion for these cases when you're using an AMDS. We're not either, but your standard approach is just unilateral perfusion over the axillary artery, correct?
Yes, but with occlusion of the left carotid and the left subclavian. Typically, if you can reach down the left subclavian and you use a clamp, especially with the AMDS cases, with the standard aneurysmic casing with an open anastomosis, the so-called hemiarch, I use a yellow Fogarty.
Mm-hmm. Another question, have you seen any distal stent-induced new entry or D-sign with this device? We do have a slide on this if you want to show it in the backup slides, Professor Borger.
Whereabouts, Chelsea?
In the backup slides at the end.
I think where it shows the difference between the T-bar and this
53.
one. Two pictures. This one, yeah. I think the answer is no, we haven't, Michael. Huh?
Yeah, exactly. Yeah. It is a concern though for any stent in a dissected aorta, and you have to remember that it's been demonstrated that the aorta expands 15 to 20% when a dissection occurs. So that's why you have to be careful that you do not overly aggressive oversize a stent in the descending aorta. If you do, you're going to get this D sign. And if you really over aggressively, you could actually even rupture the descending aorta, which, thank God has not occurred with this device, but has occurred with other devices. And that would be my one, caveat there is when you're measuring the descending aorta at the level of the pulmonary bifurcation, and if you're stuck between two sizes according to that chart, I would say go with the smaller size.
And Michael, also often the question pops up, like there has been a stent that had a similar purpose in the past, and you were kind of, you had the joy to try this in the past, and I think you have also experienced this issue, huh?
Yes, yeah, I had the very unpleasant experience of a descending aorta rupturing right in the operating room with that previous uncovered device, but it was a totally different device. It was just basically an uncovered stent. There was a higher radial force on it. There was no proximal cuff to sew to the aorta. It was just basically drop it into the descending aorta and let it go.
It was balloon
and that concept just doesn't really make sense, and the company, I don't think it no longer exists.
I think also it's important to understand the AMDS device, at least the design, how I understand it, it's relatively long, and then while it gradually expands, it foreshortens. So in the end, it's going to kind of gradually apply some radial force, but it's not like a TAVR device or any of these super aggressive nitinol designs that have high radial forces. They seem to be pretty low, actually.
Yeah, you see that nicely in this illustration here in this slide.
Mm-hmm.
Okay, Chelsea.
All right, we are at 11 at time, so I just want to make everyone aware. I don't know if we do still have questions, so if you guys want to answer a couple more, we can keep going.
Okay,
yes.
Go ahead.
All right, so next question is, in the stage of the implantation of the device, do you think an angioscopy like other groups are doing to see the true lumen and other reentries is helpful? What do you think?
So honestly, I've seen this angiography. I think we all have seen those. Now from Essen, typically, they show beautiful pictures, which made me purchase such a bronchoscopy, which is not cheap. Only one company making it. And I tried it. I was not so impressed, honestly. It takes a lot of time, and I'm not sure if the additional information that you get is worth all the hassle. Michael, you have tried it, or?
I couldn't agree with you more. I don't see the relevance, especially in comparison to the additional time that your circulatory arrest will be extended.
Mm-hmm. Next question, not to complicate a new technology, but to Dr. Borger's comment that an arch tear warrants a total arch, in parentheses, I agree, but what is the opinion on performing a zone 1 or 2 arch plus AMDS? Exclude the arch and place device in arch, would eliminate the need to go after distal arch vessels and arguably still achieve goal. What's your opinion?
Jorg, you already addressed this, but why don't you go ahead and do that one more time?
Obviously. I mean, the most typical scenario is, and this is what we have done also, is if you have a tear in a proximal arch, I think then it's faster and easier to simply transect the arch in between the innominate and the carotid. You do the AMDS in the usual fashion. You then suture single branch graft to it and then attach the graft to the innominate artery. And of course, you could also do the same with a double branch prosthesis. I mean, when you come to the stage that you use a triple branch, then I don't see the advantage. And you can go with a frozen elephant right away.
Completely agree.
Another question, are you recommending to use this in all DeBakey 1 dissections?
I've asked all of my surgeons that are doing type A dissection surgery to get trained in this. And, you know, it will take a couple more years before we know for sure, but the initial data looks good. And I would like it to be standard of care in patients without aortic arch tears. It's
similar scenario here in Berlin. So now it's the kind of routine treatment for the type A dissection, the acute ones, excluding, as Michael was pointing out, those with a primary tear in the arch, especially if the tear is in the distal arch. Otherwise, as we discussed a minute ago, we could do it zone 1 or so anastomosis. I would personally, my personal opinion, and it's also in reference to the next question, I'm a little bit reluctant to use it in very young patients where there is suspected connective tissue disease. Usually, those patients are typically, I mean, if they are stable and if they are not in deep shock, then I think those people should have a full arch eventually plus a David proximal. And this is definitely kind of a more complicated procedure where, at least this is our strategy, we would call those people who are familiar doing it. I think it's the same situation, Michael, right? A young 25-year-old suspected Marfan, you would do the whole thing.
Yeah, stents should be generally avoided in those sort of patients. I agree with you completely. Chelsea, I'm going to stop sharing my screen here and see what happens, and maybe I can see you. Ah, yeah, now I can see you.
Great.
Now I know how it works. Great.
Yeah. So if you can hand it back to me, we'll wrap up.
So Chelsea, should we kind of show that one single case that required re-intervention? We definitely do not want to hide stuff, right? And there was a question at the beginning. So if you make me the host, I can show you the case.
Okay.
Are you the host again, Chelsea?
I am, yes.
Oh, so you're empowered.
Finally.
Now you are.
Okay. So let's see if I can manage the thing here. So now I should be able to share the screen.
Yep.
Yeah, perfect. So we bring up the presentation, and I think there. Okay, I think we should show you what you can expect in regard from the CT post-operatively, because this is something that I think it's important to understand. So ideally, you will see a picture. You can see my mouse pointing, I guess, right? So ideally, you should see a picture like that. Completely healed arch and descending. This is, of course, phenomenal result, and we have seen many of those actually. More standard picture you get immediately a discharge CT scan is something like that. So you have a completely obliterated false luminate arch, and this is, remember, this was the goal. We want to treat anything in the arch, so in case we have to go back years later, we do not have to do a sternotomy. And some cases, you see something like that, where there is still false lumen in the arch. And this is usually because something is pressurizing the false lumen in the arch. And usually it's due to some entries in the supraortic vessels. And this is these cases again. So this is a type A response, so to say. So it's a beautiful response. Type B, where it's still okay, the arch is completely healed, but there is some residual flow in the false lumen. And of course, you have to sit and wait how this thing develops. Until now, 75% of those patients have shown stable or decreasing total aortic diameter, so so-called positive remodeling. But of course, in a couple of years, we will see those that might come back. And this is one of those cases, this is the only one that required a reintervention, where you see that there is an entry in the left subclavian artery here. And this was feeding the false lumen. And this has led to a pressurization of the false lumen in the proximal descending. And this patient came back with progressive growth. So this was a negative remodeling. And this was the only case that we've seen so far. So the idea on how this can be treated is that in this case, the patient received a carotid subclavian bypass, then and then a stent into the leaky subclavian, and also they coiled the false lumen. And this is then the follow-up CT a couple of months later, and you can see complete positive remodeling, so to say. So now the proximal descending is shrinking if you compare that. So there's no need for any intervention whatsoever in the future in the arch or in the proximal descending. And this is what is always said, that yes, you can use interventional techniques to address potential negative remodeling if they might occur.
Great.
Very interesting case, Jorg.
Well, thank you both very much. If you want to hand the hosting back to me. Great. Oh, all right. All right, so just to wrap things up, thank you guys all for participating. Thank you very much to our two presenters for the excellent presentations. This has been a really good session, I think, judging by the fact that we went over time. And we are looking forward to doing more of these in the future, so please be on the lookout for chapter 2 of this webinar series. We have the presenters' contact info here if you have specific questions for them. And if you have questions for us at Osiris, or you want to schedule a follow-up meeting, please reach out to us at info@osiris.com. And we look forward to, continuing to hear from you. So thank you all.
Okay, thank you. Goodbye.
Bye-bye.
All right, bye-bye.